All right. So, important things to consider, unrelated to exact questions, but pay attention to your vital signs. So, if they're unstable, like they're, hypotensive, they're tachycardic, we likely need some sort of blood products. Pretty much if blood products is an option on there, you don't choose it, you're probably wrong. So we need to consider that. Now, thinking about our primary survey, if we haven't secured an airway yet, then that's probably the right answer. So pay attention to your stem and the stem in your question on whether, they have a secured airway or not, or some of them might say they're, while securing the airway, or they're, will secure the airway and then, so pay attention to those. It's also important, recognizing, paying attention to the stem when it says definitive treatment versus what is your next best step, what is your, I know you guys love those questions. What is your next step in this? So pay attention if it says what is definitive versus your next step, or what the next treatment is. So we'll start off, let's look at, start off with chest trauma. So when would I do a needle decompression or needle thoracostomy versus a tube thoracostomy?
Unstable.
Yeah, so unstable, signs of tension physiology. So hypotensive, tachycardic, they're showing signs of extremis. Our next best step is going to be a needle thoracostomy or a finger thoracostomy, followed by a tube thoracostomy or a chest tube. So when are we going straight to tube thoracostomy?
Stable.
Yeah, that patient is stable and it's large enough. We're not really talking much about spontaneous pneumos on this one, but yeah, in those stable patients. And what do we actually do in reality? We go straight to a chest tube, but that's not the actual steps. But that's because in a trauma room, you have your chest tube there almost as fast as you can needle D, and you're just starting to cut, and you can place your finger in there, followed by the tube. So, good. All right, and then there will be some TC3 questions and March algorithm. So, if there's any massive bleeding, apply a tourniquet to wherever the bleeding is coming from, and thinking about those most common preventable cause of death on the battlefield. You're gonna need to know your different roles of care and what's involved in them. So your role 1 aid station versus role 2, what sort of ancillary staff you have versus what's a role 5? Yeah, a hospital in the United States. Okay, good. What is our recommended dose for TXA?
2 grams.
Yeah, within
3 hours.
Good. What are you gonna do if you put a tourniquet on the patient? You don't have they're still bleeding. What's your next best step for that?
Hemostatic agents. Recheck the tourniquet.
Second tourniquet, right? If it's an extremity hemorrhage, a second tourniquet now. Any of those other areas, your junctional areas, it's not going to work well. What do you think? There's going to be, at least a GCS or a few GCS questions. And the key things to remember are what GCS we want to secure that airway first. So when you're reading the question, think about that patient's presentation, what their GCS is, and what our next best step is going to be. Whether that's, secure their airway versus, resuscitate, continue our ABCs. Good. There will be, there will be images of all the different intracranial hemorrhages on there, so you need to be able to identify subdural, epidural. You also need to be able to identify some of your herniation syndromes, with your midline shift or your subfalcine herniation. What are some of our treatments for if we suspect increased intracranial pressure or herniation?
Hypertonic saline and mannitol.
Yep, mannitol, hypertonic saline, elevate the head of the bed to 30 degrees. Good. All right. Moving on. I've already talked about Nexus. Yep. Innovate again. Let's see. What sort of bleeds what special populations am I concerned about certain intracranial hemorrhages for that we talked about? Those elderly and subdural hematomas, so you have less You have atrophy of that brain, there's more space in there, and they have a higher risk for those subdural hematomas. Good, good, good. What is the most common spinal injury location? Cervical spine. Yeah, good. And then for like intracranial hemorrhage or signs of herniation, when would I do? When would I consider hyperventilation? Yeah, really, we rarely, almost never consider it. There are instances if they're acutely herniating, it can be a temporizing measure, but we typically avoid hyperventilation in our TBI patients. What are some exam findings I might have for like a complete forward spinal cord injury? Yeah, priapism. Yeah, I got all of them.
Loss of sensation.
All right. That one should be easy. Oh, when anybody remember? I wasn't at the airway station all the time, but what did I mention at the airway station? Does anybody remember that when I was there? Yeah, there will be some questions regarding like your 7Ps. So, some of it, how long are we looking at like pre-oxygenating patients for?
3 minutes.
Yeah, 3 minutes, 8 vital capacity breaths, good. What's our gold standard for confirming ET2 placement? Other than
Continuous
watching it go
vapor
to the course.
capnography.
Yep, end-tidal CO2, good. When would you consider like a surgical cripe?
Can't get airway.
Yeah, like massive facial trauma, you can't establish, or you're unable to intubate or you failed intubation. Any mid-phase trauma, good. Good. What are some of the reasons I would use ketamine as my sedative for RSI?
Bronchodilator.
Yep, so bronchodilator. What else?
Hypotensive patient.
Yeah, hypotensive patients, good for blood pressure control. Perfect. And what's the simplest ventilator setting that we use in the EO?
Assist control.
Yeah, assist control, good. You guys got this one. All right, you will need to know when we would just, proceed with an emergency department thoracotomy, so know your indications for that. And, the most likely patients to survive, like that penetrating stab wound, witnessed signs of life. There'll be some ultrasounds on there as well, so just, be able to recognize some of the different ultrasound findings, like especially for pericardial effusions. Let's see. What are some contraindications to my paralytics?
Crush, burn, innervation energy.
Yeah, so which paralytic is that contraindicated?
Succinylcholine.
Yeah, succinylcholine, good. You need to know the rule of tens. There'll be calculation. I'll be very disappointed if you have to use a calculator, but that's fine. It's pretty simple. There will be some images on some of those cervical spine fractures, so be able to identify those on there. And the different types, like your Jefferson versus hangman versus, clay shovelers and those sorts of things. What is so let's say we're worried about following our TC3 type algorithm, significant contaminated wounds, what's our antibiotic of choice? Yeah, erdafitinib. If they're minor, then you can look at Moxie or something like that. But typically, we're using those big guns for those. Let's see what else. Oh yeah, here we go. All right. So, what is our pre-hospital treatment for frostbite injuries?
What kind of pre-hospital?
Yeah, like pre-hospital. You know, what's our concern in the pre-hospital setting?
Refreezing.
Yeah, like a refreezing injury, good. So, we need to consider that, we're treating those frostbite injuries. So what is some of our like basic treatment if we're in the field and we can't immediately rewarm them? Yeah, good, yep, perfect. Yep, pain medicine, mobilize, elevate. All right, and then what is our treatment for heat stroke?
Mild heat.
Yep. Take them out of a fire. I love how that was out. Remove them from the burning area. Thanks. Yeah, so we want to, start some sort of cooling. What do we prefer?
Evaporative.
Yeah, evaporative cooling. Good. And then what about, like a stable patient with heat exhaustion or heat stress? What's our treatment for that?
Oral rehydration.
Yeah, oral or IV hydration, some sort of electrolyte solution. Good. All right. What else we got on here? Well, these are, I think, easy, but just remember your different mechanisms for looking at your intra-abdominal injuries. Like I said, your common question, somebody takes handlebar to a certain area we worry about versus whether they have, ecchymosis or a seatbelt sign. What are our different treatments? Whether, obviously, like I said, look at the vital signs. Are they stable or unstable? If they're unstable, they're almost always going to the operating room, exploratory laparotomy. But you also need to consider like things you can do right now, blood products, immediately, especially if they're hypotensive. You want to start doing some sort of treatment for those patients. What else? Yeah, it's a lot of just resuscitate, Give them an airway, give them some blood, send them to the operating room. Yeah, I think that's all I got here. If you paid attention during the check on learnings, those are going to be helpful. We've covered everything. I think you guys are going to do great. What questions you guys have about this test? Lasting maintenance. So for block 5 is going to be a hands-on performance examination. So you're going to be required to do an EFAST exam, and you'll be graded on it. And then you should have a choice between the ocular ultrasound versus the DVT. So those are the ones we test you on. Usually we give you a choice which one, but some instructors don't. Some graders will be like, nah, man, you're doing this one. So, we need to be proficient at those. And you will be. We're going to practice. Most of ours, block 5 is going to be a quick slideshow to kind of present landmarks and what you're looking for in those areas. And then you're going to just scan each other, and we'll, rotate around. We have quite a few different machines to scan on. We'll have to convert some tables into scanning, but anybody have questions before we roll into ultrasound? Yes.
So again, the use for the nexus criteria is to determine whether or not we need to do imaging for spinal injury.
Yep. So yeah, if they meet all the criteria, we don't need to do imaging. If we have any concern from it, then we need to do imaging.
It has to be all of that criteria. It needs to be that.
No, just any one of them, then we would look at imaging in those patients. They don't meet the nexus criteria.
One more thing.
Yep.
Would it be good to know the classifications of hemorrhage based on blood loss, all those numbers, like classes, burden?
No, understanding lower the blood pressure, higher the heart rate is probably bad. And we need to do something like give them blood back if that's what they're missing. And it's never, it's not neurogenic shock, I'll tell you that. So if they're hypotensive and they have a bradycardia, then maybe start thinking about your neurogenic shock. But that's why I said pay attention to the vital signs when we're looking at those. And let's roll into this. May need to turn the lights off for this. I don't know why the screen's not working over here. Oh, I think we got one of those down. Hold on.